session is on psychotic disorders for behavioral science and psychiatry for Falcon Physician Reviews. Psychotic disorders such as schizophrenia are those in which the patient cannot differentiate what originates within oneself and what comes from outside the self. So they have an impaired reality testing. For schizophrenia, symptoms have to be at least for 6 months, and they must have some positive symptoms and negative symptoms, and we'll go into those symptoms in further slides. Schizophrenia is a characteristic psychotic disorder, and we will talk about that in more detail. An important prevalence information for schizophrenia is that 1% of the general population has schizophrenia. Important information about the prevalence in families, and this is very high yield for the exam. So on the exam they will say, if you have one sibling affected with schizophrenia, then you have 10% chance of being affected. If you have one parent with schizophrenia, then you have 13% chance of being affected. If you have both of your parents affected by schizophrenia, then you have a 35 to 45% chance of being affected. And if you have a monozygotic twin which is affected, then you have a 50% chance of getting schizophrenia. These numbers are very important. I would definitely know this number for your exam. Schizophrenia is more common in the lower socioeconomic class, and I think of this as a downward drift phenomenon, meaning that when you get schizophrenia, you don't function very well, you can't earn very much money, and you drift down into the lower socioeconomic class. So why do people get schizophrenia? There are a couple of different theories. One is that there is too much dopamine in your brain, and this is causing these abnormal symptoms. A viral illness, as many people who have schizophrenia are born during the winter months. And the third one is possibly because of brain abnormalities. So on the next slide, you're going to see multiple different hypotheses of where they think the reasons for schizophrenia are the problems. So we talked a little bit about you have too much dopamine in your brain, and that's what's causing it. Brain abnormalities include hypofrontality, meaning decreased frontal lobe functioning, which causes the abnormal cognitive dysfunction in schizophrenic patients. Also, it's noted that they have cortical atrophy as well as enlarged ventricles. And the glutamate abnormalities, an important point is that PCP and ketamine cause negative symptoms by antagonizing glutamate receptors. So that's where they get the glutamate hypothesis. And that's a very important high-yield USMLE point. And the serotonin imbalance is that some atypical antipsychotics antagonize serotonin receptors and have shown to improve some of the negative symptoms. So they think maybe serotonin might also play an important role in schizophrenia. For the differential diagnosis of schizophrenia, you must rule out any causes due to drugs or medical conditions. Drugs, including cocaine and amphetamines, are very common offenders, as well as PCP and ketamine. You also want to rule out medical causes such as Wilson's disease, Huntington's disease, Parkinson's disease, before you consider a diagnosis of schizophrenia. In your psychiatric illnesses, you can differentiate schizophrenia from brief psychotic disorder, schizophrenic-form disorder based on time periods. You want to rule out a delusional disorder. And you also want to rule out, is it a possible mood disorder with psychotic features? So there's a lot to think about before you diagnose someone with schizophrenia. Typically, schizophrenia starts pretty early, about the ages of early 20s, sometimes even around 18 when they first go to college. That increased stress might kind of bring out this schizophrenic attack or bring out these symptoms. In women, though, it generally occurs in the mid to late 20s. Men are usually affected earlier. And it doesn't always have to be precipitated by a stressful event, but it can be. They usually have impairments in social and occupational functioning. Deterioration is due to both the negative and positive symptoms. A majority of schizophrenic patients smoke tobacco, and this is important to know because tobacco actually decreases the levels of antipsychotic medications, so you have to increase the dose of antipsychotic medications. A good USMLE question is a patient who has schizophrenia starts smoking and you increase the drug levels and he decides to come off of smoking, and all of a sudden he has very bad side effects from the medications that he's been stable on for a long time. What happened? Well, he stopped smoking, so therefore you should have decreased his levels of his medications as well. Physical exam will also show that they'll have abnormal eye movements or saccades. And what saccades are is that basically they'll have a hard time moving their eyes to look at specific points, and they'll be moving them rapidly and have a difficult time focusing on one thing. So what are the effects of schizophrenia? They affect perception, they affect thought, emotions, and behavior. So perception is hallucinations. A majority of the patients will have auditory hallucinations, then followed by visual, followed by olfactory, gustatory, and tactile. Now, if you have a patient who's older and has a new onset of visual hallucinations, that most likely will not be schizophrenia. That most likely will be some kind of delirium or some kind of psychosis due to a medical problem. Schizophrenics generally are diagnosed when they're younger, and they primarily have auditory hallucinations, and some will have some visual hallucinations. They might have some unusual sensations such as shocks or feel jolts running through their body. They may have some derealization or depersonalization. Their thought content will also be different. They will have something called delusions. And what delusions are fixed false beliefs. And in schizophrenia, they generally tend to be persecutory, which means paranoid or feel like people are coming after them, grandiose, they can be hyper-religious, or they can be somatic. So a patient will come and tell you, I feel like people are coming after me, and there's no way that you could tell this patient that he's not right. He will not believe you. He is so fixed on his belief that people are coming after him. They'll also have ideas of reference, which means that the TV or the television is giving them messages or other people are giving them messages. They'll feel like their thoughts are being broadcasted out and people can read their minds. They'll feel like they're being controlled, that people are putting their thoughts into their mind, or they'll feel like people are pulling thoughts out of their mind, which is thought withdrawal. They won't have proper boundaries. Their thought form will also be abnormal. They will have looseness of associations, which means that you can't really follow their trail of thinking. They'll be jumping from topic to topic with no real association. They'll have circumstantiality, which means you ask them where they live, and they might start off, but then they'll go off and ramble, and maybe finally get back to where they live. Tangentiality, where they'll start off talking about something, but then they'll go off onto another topic and never quite complete what you want them to say. Word salad means just bunched up words that really don't go logically together. Echolalia, they'll repeat what you say. Neologisms is when they make up new words that have meanings for themselves. And perseveration means that they repeat the same thing over and over again. They have a hard time moving from one topic to the next. They may also have some thought blocking, poverty of content, mutism, and aprosodia, and that means the kind of tone that they have is lacking. So they'll have a very flat, monotone language. Emotions, which are usually reduced in schizophrenics, so usually very flat, very blank. They might have inappropriate or bizarre responses, and they might even have a heightened emotional sensitivity. Frequently, they don't pay attention to their grooming, their dress. They'll have stereotypies, which are repetitive behaviors. They'll have echopraxia, which is doing the same behaviors of someone else. So they're mimicking the behaviors of someone else. They'll withdraw from other people. They will have abnormal eating and drinking patterns. So how do you differentiate these between positive and negative symptoms? So your positive symptoms are going to be your delusions, your hallucinations, and these symptoms actually do better with medications. Your negative symptoms are going to be your blunted affect, your poverty of speech, disorganization, your cognitive difficulties. And these symptoms are much more difficult to treat. The atypical antipsychotics have been thought to help much more than the typical antipsychotics, but still more difficult to treat. So there are 5 subtypes of schizophrenia. First, you have your paranoid type, where it is the most common and where feeling paranoid is the most common delusion. You have your disorganized schizophrenia, where they have both disorganized speech and behavior. Catatonic schizophrenia, where they become immobilized, they have rigidity, echolalia, catalepsy. Catalepsy is where they have waxy and wavy flexibility. If you were to lift their arm and put it in the air, they would just leave it there until you moved it again. Undifferentiated is that it's not characteristic of any of the subtypes of the other schizophrenias. And then you have residual, where you have treated the positive symptoms of schizophrenia, but the negative symptoms continue to remain. So how do you treat schizophrenia? Hospitalization is required if the patient is very aggressive or is actively acting on their delusions in a dangerous fashion. Antipsychotics are frequently used either alone, or sometimes we'll use them in combination with a mood stabilizer or antidepressant, depending on the symptoms of the patient. But antipsychotics are the most important. Psychosocial treatments are very helpful, such as family education, social and vocational skills training, roommates, daily activity. These guys do very well if you give them a similar daily activity every single day and they have a schedule. They don't do well with change. They don't do well with increased emotions. They can even work in some jobs. A lot of paranoid schizophrenics actually work as security guards, which you can see is actually pretty helpful because they're always kind of on watch, so they would actually make pretty decent security guards. But you also need to be aware, and this is an important USMLE point, that about 10% of schizophrenics will commit suicide. So just like with major depression, you must assess their suicidality. In any psychiatric patient, always assess suicidality. Board question again that we're going to talk about right now is that the factors that are associated with the best prognosis are a sudden onset, when you're older and more positive symptoms, when you're married with a good social support, when there's an obvious precipitant, there's mood symptoms involved as well as paranoid symptoms. Females have a better prognosis, and paranoid type is also a better prognosis, and confusion associated with the episode is also a better prognosis. Next we have schizoaffective disorder. So what schizoaffective disorder is basically, this is someone who has schizophrenia or psychosis a majority of the time, but they also have a component of mood alongside with the schizophrenia or the psychosis for a majority time as well. So for example, if they've been psychotic for a year, they will also be feeling depressed for 8 months out of that year. But there must be at least a 2-week period where they are psychotic without any mood symptoms. So that is what schizoaffective disorder is. And a differential for schizoaffective disorder would be mood disorders such as bipolar disorder with psychotic features or major depressive disorder with psychotic features. These guys usually present to their mid to late 20s. They have all the similar symptoms of schizophrenia, but the addition of either a manic episode or a depressed episode. And again, it has to be for a significant portion of the psychotic portion. And you'll treat them just like you do schizophrenia, with hospitalization if necessary. And you'll treat them with a mood stabilizer, an antipsychotic, and antidepressant as needed. Now, schizoaffective, because it has an affective component, which means it has a mood component, has a much better prognosis than schizophrenia. Next, we have schizophreniform disorder, which they meet the same criteria as schizophrenia, but you have to look at the time period. That's the only thing that differentiates this from schizophrenia. So it has to be at least for 1 month, but no more than 6 months. And there's typically less social withdrawal with schizophreniform disorder. You treat it the same way that you treat schizophrenia, and eventually you might not need to keep them on medication for a very long period of time. Brief psychotic disorder is the same symptoms of psychosis with the delusions and the disorganized speech and behavior, but it only lasts between 1 and 30 days. There may or may not be any kind of acute stressor, and if it occurs within 1 month of having a baby, it's called postpartum psychosis. For this, if the patient is in acute danger to self or others, you can treat them with hospitalization. You might need a short-term treatment with antipsychotics. Otherwise, the disorder is self-limiting and will go away by itself. So the differentiating factors between schizophrenia, schizophreniform, and brief psychotic disorder is the time periods. Delusional disorder is a chronic disorder, and to differentiate this between schizophrenia is that the delusions are not bizarre. Whereas in schizophrenia, the delusions are very bizarre. Like, they will think that there is electricity coming out of their head, or they will think that God is talking with them, or it'll be very bizarre. You know that it really can't happen. The FBI is only following them because they've done something wrong. So those are going to be the very, very bizarre delusions of schizophrenia. Whereas a delusional disorder patient won't have bizarre delusions. They will have much more simple delusions, and you might even think to believe them. And it might be something like, I think my wife is cheating on me, my husband is trying to poison me, and actually you might not even notice that a patient has delusional disorder because they actually walk around in public and you won't notice it unless you happen to stumble over it in conversation. They have to have the delusion for at least 1 month, and the delusions are circumscribed. They're about that one particular thing they have the delusion about. And usually no functional impairment other than what's associated with the delusions. So there are different subtypes of delusional disorder. There's an erotomanic, which means they believe someone else is in love with them. There's the jealous, where they feel that someone's being unfaithful. The grandiose, where they feel they have special powers and more important than others. Somatic, they believe they have a bodily dysfunction. Mixed, which is a combination of the above. And unspecified, where they don't meet any of the above criteria. It's very rare. It's found frequently in people who immigrate from a new country, and it is more common in family members of those with delusional disorders. How do you treat this? Antipsychotic medications can be used, but they're generally not very helpful. The best thing is to put the person in therapy, and honestly, we generally tell them not to talk about it, to not tell people about it, to keep it to themselves, because they generally function in a very good way if they don't talk about it. So here we have a table of just separating all of these psychotic disorders. With the schizophrenia, it has to be at least 6 months with these psychotic symptoms. Schizoaffective disorder, you have predominant psychosis and predominant mood symptoms, but there's a 2-week period where you only have psychotic symptoms. Schizophreniform disorder, it lasts from 1 month to 6 months. Delusional disorder is non-bizarre delusions, has to last for about a month. You usually won't get any hallucinations from it because it's a delusional disorder. Brief psychotic disorder, it lasts about 1 month and self-limiting and has psychotic symptoms. Antipsychotic medications. So antipsychotic medications are used to treat psychotic disorders, as the ones that we've discussed, mood disorders with psychotic features, and also very helpful in treating patients who are severely agitated, who are using drugs and very combative, helps calm them down. There are different classes of medications. The atypical antipsychotics, which are our newer generation of antipsychotics, have been shown to help the negative symptoms of schizophrenia. And the one medication which is the most effective for this is clozapine. We have a list here of our typical antipsychotics and our atypical antipsychotics. If you have a choice on the exam as to whether you use atypical or typical antipsychotics, you'd much rather use the atypical because they have less side effects, they're more tolerated, and they work better for the negative symptoms. So you generally want to use the atypical antipsychotics. So how do antipsychotic medications work? Well, we think that schizophrenia or psychosis is caused by too much dopamine. So the primary way that these medications work is by blocking dopamine receptors. They'll also block some histamine receptors, acetylcholine, norepinephrine receptors as well. But the main function is the dopamine receptors. And the typical antipsychotics are pure D2 receptor blockers. whereas the atypical antipsychotics block both D2, D4, and serotonin receptors, which are your 5-HT2 receptors. And because the atypicals block both the D2 and the 5-HT2 receptors, that's why they think that you have less movement disorder side effects in the atypical antipsychotics. So how do you choose medications for patients with psychosis? Again, you want to look at family history of people being on antipsychotic medications, previous medications they've been on, do they have any side effects from these medications? If you've been on multiple antipsychotic medications and they're not working, then you might consider a treatment of clozapine, which is a gold standard treatment of schizophrenia, but we don't use it all the time because of its risk of agranulocytosis, and that's an important USMLE question. Clozapine's most common side effect is sedation, but the most dangerous side effect is agranulocytosis, which only occurs in about 1 to 2% of the population who take it. Haloperidol, olanzapine, and ziprasidone are very helpful to use in patients that are agitated because you can give it to them in an intramuscular form. Risperidol, haloperidol, perfenazine, or fluphenazine can be given in an injectable form where the patient does not have to take oral medications but can take a long-acting intramuscular preparation where they only need to get the medication 2 weeks for risperidone and 3 to 4 weeks for haloperidol and fluphenazine. And there are also certain preparations of the medication where if you're worried that the patient's cheeking the medication, he's keeping it under his tongue and spitting it out later when the nurses leave, you can give them a rapidly dissolving formulation of the medicine that as soon as it hits their tongue, it dissolves and they can't spit it out. What are side effects and adverse reactions to the medications? Sedation can be a problem due to the antihistamine reaction. They can get anticholinergic side effects such as urinary hesitancy, dry mouth, blurry vision, confusion. Other side effects include conduction effects, and that's especially significant with dioridazine and ziprasidone, and that is an important USMLE question, as well as the agranulocytosis with the clozapine, which is again an important question. Important side effects of antipsychotic medications are your extrapyramidal symptoms. So extrapyramidal symptoms are probably the most common known side effects of antipsychotic medications, and they're thought to be due to blocking dopamine in the extrapyramidal system, in the nigrostriatal tract. And what it does is it causes an increase in acetylcholine, which causes them to cause muscle to contract and cause these abnormal muscle movements. So there are 3 different types of extrapyramidal reactions. There's the dystonic reaction, there's akathisia, and there's Parkinsonism. Acute dystonic reactions, risk factors, high-potency medications such as haloperidol are more likely to cause EPS reactions or dystonic reactions. Also, majority of patients will get them within the first couple of hours or first couple of days. If you rapidly increase the dose of medication, there's an increased risk of dystonic reaction. And also with intramuscular administration, they have noticed to have an increased amount of dystonic reactions. Patients who have a large muscle mass, young, African American males also have an increased risk of getting acute dystonic reactions. How do you diagnose this? Generally, they will occur pretty frequently right after you start an antipsychotic medication, but they can really occur at any time. They are localized to one or a few muscle groups, most commonly in the head and neck, and there's no alteration in the consciousness, there's no alteration in their vital signs, but they are visibly very uncomfortable. How do you treat it? Well, I explained that actually the cholinergic system is increased due to the blockade of dopamine in the nigrostriatal tract. So since you have too much cholinergic activity, you need to give them an anticholinergic medication. So that would be something like benztropine or trihexyphenidyl. But diphenhydramine can also be helpful because it has anticholinergic action. How do you treat this? One, you can either reduce the medication dose, and this will decrease, slow down the rate at which you're titrating the medication. Consider an alternative medication, like switching to a different class. If you're using a typical, switch to an atypical. And you can usually decrease the amount of dystonic reaction as you continuously take the medication. Next, we have Parkinsonism. This generally happens days to weeks following administration, and it looks just like a Parkinson's patient. Very frequent in the elderly. These patients have the blank faces, the bradykinesia, the resting tremor, the rigidity. And you treat by reducing the amount of antipsychotic medication and, if you need to, anticholinergic medications. Next, we have akathisia. And what akathisia is that it happens hours to days after administration. And what the patient will tell you is that they can't sit still. They have this feeling of restlessness. They really feel like they need to get up and move. They're agitated. They're irritable. And you need to ask them the difference. You need to ask, hey, are you feeling restless? Do you feel like you just have to move yourself, or are you just really angry? Because sometimes they can tell you that they're feeling really restless. How you can treat this is you reduce the antipsychotic medication, and you can either give a beta blocker or a benzodiazepine works better for akathisia. If that's not helpful, you can also give an anticholinergic medication. Neuroleptic malignant syndrome is a very severe life-threatening illness with antipsychotic medications, but luckily it is very rare. And it is seen more common with the high-dose typical antipsychotics, and it can occur at any time during treatment. We have also seen neuroleptic malignant syndrome with the atypical antipsychotics, but it is less common than with the typical. And what you do in this situation, if you have a person that comes in with neuroleptic malignant syndrome, they're going to have elevated white counts, they're going to be stiff as a board, they're going to have fever, altered mental status, and what you're going to do for them is stop their antipsychotic medication and give them supportive treatment such as fluids, put them in the intensive care unit, and you can give them benzodiazepines to help with their agitation if they have any. Once the acute symptoms have resolved, you can try starting back an antipsychotic medication, probably an atypical 2 weeks later, but you generally, if you don't have to start it back, you generally don't want to. And if it's very severe and you're having a hard time treating it, dantrolene and bromocriptine can also be used. Tardive dyskinesia is a long-term side effect of antipsychotic medications, and this does not come under the classification of the EPS or extrapyramidal symptoms. So tardive dyskinesia, the risk factors for this is more of the typical, more than atypical neuroleptics. An elderly female is more likely to get tardive dyskinesia. If you have an affective disorder, you're more likely to get tardive dyskinesia. And also if you have a neurological illness, diabetes, or history of EPS. Usually occurs late in antipsychotic treatment, very gradual in onset, and generally affects your lips, sometimes your hands, but it's this constant moving of your lips and mouth that the patient cannot stop or control. What you can do is to reduce the amount of antipsychotic that you're giving at that time. When you first reduce it, it will actually increase the movements and then it'll slowly decrease them. Or you can switch to an atypical antipsychotic which has a less likelihood of causing it, or clozapine. And other treatments that they've tried but are not effective are vitamin E, dopaminergic agents, or benzodiazepines. The problem with giving a dopaminergic agent is that you're worried that if you add more dopamine, you'll make them psychotic. This concludes our section on psychotic disorders for behavioral science and psychiatry for Falcon physician reviews. This concludes our section on psychotic disorders for behavioral science and psychiatry for Falcon physician reviews.